A pleasant good evening, everyone. Let's begin today's session with Omkaram. Om. 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 Now, NMO mantram. Natvaham kamaye radhun, na swargam na punarbhavam, kamaye dukkadaptanam, pranina murtinashanam. Warm and heartfelt welcome to all the participants of NMO AP Med-Katalyst Foundation, the 0 Hour Revision Series. Today is day 2 of our 15 days rapid revision series, an initiative aimed at strengthening the fundamentals of first year MBBS students through focused and high yield revision series. Anatomy, building the foundation of medicine. Today, Dr. Shubadra Devi ma'am, Professor of SVMC Tirupati, is going to take the session. Today, topics to be covered are upper limb, brachial plexus, Klumpke's paralysis, mammary gland, axillary lymph nodes, and cubital fossa. It's our privilege to have Dr. Shubadra today with us. We sincerely thank you for graciously accepting our invitation, ma'am. With great respect, now I would request Dr. Shubadra ma'am to kindly take over the session and guide us with your valuable insights.
Thank you. Good evening, one and all. Hope I am audible. And the topics are larger ones, and I try to complete it. And this is a rapid session, and it's a revision part because now already you are ready for the examination. For the last minute, the 0 hour brushing up, this will be of help. And let me start with the brachial plexus. It can be given as a long question. So asking for the formation, course, branches and relations, and putting a question, what is prefixed and postfixed type of brachial plexus, and the relations of cords and branches of plexus to the axillary artery. Ebb's palsy and Klumpke's palsy are the important ones regarding the brachial plexus. And if you see, we are going to cover under these aspects and a little bit about the branches from the roots, trunks and cords, and focusing on the applied aspects. And if you see the brachial plexus, it is for sensory, motor, vasomotor and secretomotor innervation for the upper limb. And you can see the brachial plexus and its location. And it is located in the posterior triangle of the neck between the scalenus anterior and medius muscles. And the spinal nerves that are contributing for the formation of the plexus are the ventral rami of C5 to C8 and T1. The variations are possible. They are the prefixed contribution from C4 is more and postfixed if the contribution from T2 is more. And we will be seeing at the location of it, there is a part of brachial plexus above the clavicle and part behind the clavicle and part below the clavicle. And the basic components of the brachial plexus are the roots, trunks, divisions, cords, and branches. If you keep your 5 fingers, 2 fingers are above the clavicle, middle finger is behind the clavicle, and the 2 lower fingers, other 2 fingers, they are below the clavicle. That's how you can remember about the brachial plexus. And if you see the basic plan of the brachial plexus, so I already told you what are roots and what are trunks. The trunks are formed by the union of C5 and C6 forming the upper trunk and C7 continuing as the middle trunk. 8 and T1 continue joining and forming the lower trunk. And afterwards, each trunk, it divides into 2 divisions. One is ventral division, the other is dorsal division. And if you see the fusion of all the 3 dorsal divisions will form the posterior cord, and ventral divisions of the upper and middle trunks, they will be contributing for the lateral cord, and anterior division of lower trunk will continue as the medial cord, whereas the 3 posterior divisions will form the posterior cord. And the branches from the Each of these cords you can remember as 3 branches from the lateral cord, lateral root of median, lateral pectoral and musculocutaneous, and the branches from the medial cord or the medial root of median, medial pectoral, medial cutaneous nerve of arm and forearm, and ulnar nerve. Then the branches from the posterior cords are 5 in number. Upper and lower subscapular you can remember like that, and the nerve to latissimus dorsi, axillary and radial nerves. Then what is prefixed type of brachial plexus? If there is contribution from C4, which you can see in this picture, then it is called, then the contribution from T1 you may not see or it will be less. That is called the prefixed type of brachial plexus. And if the contribution from T2 is more, and then it will be called the postfixed type of brachial plexus. Then if you see, what about the branches from the brachial plexus? There are branches from the roots, trunks and cords, and regarding the trunks only the upper trunk will give branches. Then the important branches in relation with the roots of it, which has got applied importance, is the dorsoscapular nerve and the long thoracic nerve. Others are it can contribute for the phrenic nerve and the muscular branches to the longus colli and scalene muscles. And the dorsoscapular nerve is known as the nerve to rhomboids. It supplies the levator scapulae and rhomboids muscle. That is, and it has got the supplying the muscles that are concerned with stabilization of the scapula. That is another point you have to remember. And these are the muscles. I am not going into their origin insertion because we are focusing on its nerve supply. You can see where they go: levator scapulae, rhomboids minor and major. These are the muscles it will supply, and it can get entrapped in the scalenus medius muscle. So you can see in relation with the scapula, these muscles and the nerve supply. So what will be the cause is lifting heavy weights on the head is the commonest cause for the entrapment of it. And now let us see a clinical case scenario. Sometimes you will get a clinical case scenario and a question will be followed by that because of the early clinical exposure, and you should be prepared to give analysis for a case. So a laborer who is carrying heavy weights on his shoulder, especially the right shoulder, complained of pain in the scapula and shoulder, discomfort when sitting against a chair. And inferior angle of scapula was rotated medially and the medial border of scapula was prominent. So followed by the clinical case scenario, you will be asked a question: what do you call this condition? What is the cause? Why there is prominence of vertebral border? How will you test the patient? These are the questions. Then if such a question is given, you should know for a nerve, what is that you have to keep in mind when you are answering is origin, root value, course, distribution, surface marking, and clinical importance. Now, from this picture, you can see what are the roots contributing for the long thoracic nerve and how it traverses along the medial wall of axilla, which is where you will see the serratus anterior with its 8 visitations, for which it will supply you are seeing. And you are seeing the insertion of the serratus anterior along the vertebral border on the costal surface. That also you have to recollect for the explanation. So this is how it is supplying it, and it is a external respiratory nerve of bell. It's the other name for it, and posterior thoracic nerve. Then if you see how it traverses, you can have a flow chart like this where it will be starting and how it enters the apex of axilla, and behind the axillary vessels it traverses, then along the medial wall of axilla, and giving distribution to all the 8 visitations up to the lower border of serratus anterior. That's how you can plan, so that this will reduce your time, and then you will be able to answer appropriately for the question. So this is how you can draw also a simple diagram with this one. So remembering is 5, 6, 7, raise your arms to heaven. So this is the action of the serratus anterior muscle. And So winging of scapula is the clinical condition. So what is the susceptibility for injury is because the nerve is exposed, it is superficial. There is a reason of it, and it causes a scapular forward movement, that is the action of the serratus anterior. Paralysis will cause the inability to do that protraction movements. That's why the medial margin of scapula, where you will find the insertion of this muscle, it will project backwards, which is called winging of scapula. So what do you call the condition? You got Down's injury to which nerve, and in whom it will be? Those who are carrying heavy weights on shoulder, if there is a blow on the posterior triangle, and radical mastectomy, most common cause for injury for this nerve. So why it is prominent? Now you can give, because of the, along with the serratus anterior and the trapezius, both are concerned with the overhead abduction, above the head abduction of arm. So in that there will be rotation of scapula which will be affected. So that, how will you test the serratus anterior? Asking the person to stretch his upper limbs forward, place his palms against the wall and push them against it. That's how you will test it. And then I'm showing you another case scenario which you can easily identify. So a mother with a child of, she has come to the pediatric OP and history of forceps delivery. So what will be the diagnosis by looking at the position of the baby? So what is the cause? And you have to give anatomical explanation. Like that also you may get a question. And what you have to know is the branches from the upper trunk of brachial plexus, and C5-6 unit to form the upper trunk, and each one divides into anterior and posterior divisions, and at that point it gives two nerves, that is nerve to subclavius and suprascapular nerve. So the root values are C5 and C6. You have to know about this part, and this is called Eppes point. And what is its location in relation with the clavicle? So 1 inch above clavicle and at the level of C6 vertebral level. And it's also called Erbdachny palsy, Eppes palsy, or upper plexus palsy. And what will be the cause for it? So birth injury, as in this case, forceps delivery you can cause, and indirect violence due to undue separation of head and shoulder. So you can see in that this is the one possible cause. You can see here in the normal delivery, and if the shoulder dystocia, if it is attached to coming in contact with the hard surface. So then also, and if one at the time of delivery, if excessive traction is applied on the C5 and C6 roots of brachial plexus. These are the causes for Eppes palsy. And at birth and blow. And what will be the position of limb? It is called the waiter's tip or policeman's tip. So upper limb hanging by the side, arm adducted and medially rotated, forearm extended and pronated. So that position you will be seeing, and you should be able to give explanation for each of it and what muscle is paralyzed. So depression of clavicle, subclavius muscle it will supply. So that means which nerve is affected. Arm hanging by the side of trunk and rotated medially. So axillary nerve supplying the deltoid, and suprascapular nerve, that is the supraspinatus, infraspinatus, and teres minor. They are responsible for that. And what about the musculocutaneous nerve is also affected because of the coracobrachialis. So whichever is receiving from C5 and C6 roots, they will be involved in these cases. So what will be the cause for this forearm positioning? Then the musculocutaneous and radial nerve both will be coming because of supinator is there. And then what about the palm? Extensors are weak and fingers extensors are weak. That's why the radial nerve is involved. So this explanation you should be able to give. So now you know what are all the nerves involved and why waiter's tip position. And what nerves you should remember. If it is given as an MCQ, you should be in a position to answer. So what about the lower trunk? Okay, Klumpke's paralysis, we call it. If there is injury because of hyperabduction of arm, it can be possible. And C8 and T1, they are the main contributions to the median and ulnar nerves. And it can result in claw hand or harness syndrome. So by looking at the picture, you can say what is the cause for it and what is for the cause for the traction on the 8 and T1 roots. So butt injury, difficult breech delivery, pulling the limb. You can see falling from height, one will catch an object. Then also it is possible. Cervical rib also can cause that. So deformity is claw hand and Horner syndrome. You can see what is motor loss. You should be able to. And what are the muscles that are paralyzed? All the intrinsic muscles which are supplied by the ulnar nerve, claw hand deformity. Sensory loss is along the medial forearm and hand, you will see. And whereas the autonomic disturbance is the Horner syndrome. So what is Horner syndrome also is a question for you. So that also you should be able to give. And what you should be able to give, what is the motor loss in the case of claw hand, paralysis of pronator, paralysis of flexors of wrist. And what about hyperextension of metacarpophalangeal and flexion of interphalangeal joints you are seeing. So that you have to give the explanation. Sensory loss is along the medial border. In the case of EPS, along the lateral. So that's how you can differentiate them. So this is Horner syndrome, autonomic disturbance. So there is constriction of pupil, drooping of upper eyelid, you can see, and posterior displacement of eyeball in the armpit you are seeing, and absence of sweating of face and forehead. These are the features of the Horner syndrome. So, and another thing is you should know the relations of the brachial plexus cords. So in relation with the axillary artery, the first part, second part, and third part, which will be differentiated in relation with pectoralis minor muscle. This also you should remember, because the axillary artery is having relations for the brachial plexus. That is another point you have to remember. And if you study about the axillary artery and its branches and its relations, it will be useful both for answering a question on relations of brachial plexus and also axillary artery relations. All of you are having a pictures like this in your books. So, but try to find out by keeping the directions. What is anterior, posterior, lateral and medial, and in relation with the first part, what is anterior to it, what is posterior to it, lateral to it, medial to it, and the relations of the axillary artery, vein, and the various cords of brachial plexus, how they are related to it for the first part. So what will be the position, posterior and lateral or above, and then the medial is behind it, and later on for the second part. So posterior cord is posterior, lateral cord is lateral, medial cord is medial. For the third part, the branches are related to it. The branches of medial cord, lateral cord, and posterior cord, they maintain that relationship. So by reading and seeing with the pictures, you can understand and reproduce. So both, if you read together, it will enhance your learning. So like that, you can organize the relations of each part, anterior, posterior, medial, lateral, by looking at that picture. So which is already there in your books. So you can look for the dissection images also, what is their relation of the brachial plexus and its relations with the axillary arteries. Practice it, simple diagram. So this is another simple diagram which you can practice to draw, and the branches from the roots, from the trunks, you know, the cords also. Now you are thorough with that, and how to simplify it. This is a black and white diagram drawn by one student only I am showing, and still simpler way of drawing a diagram also I am showing you, so that you can practice whichever is convenient for you. So this is the one. Then this is another picture. So how you can remember the branches of it. So first part 1, second part 2, third part 3 branches of axillary artery you should be able to recollect. And another thing is what are all the nerves with root values C5 and 6 also you combine and read. So it will be helpful for answering an MCQ or a clinically oriented question, and for the remembering the nerves of medial cord, posterior cord, and the terminal branches also. So there's a 5 terminal branches: musculocutaneous, median, ulnar, radial, and ulnar nerves. So axillary nerves. So that you should remember them. Then, so what is the difference between the upper brachial plexus injury, lower brachial plexus injuries? What nerve roots, what nerves, and what is the position of the hand? What is the sensory loss? Where on the, it's on the lateral side and on the medial side. This is how you have to differentiate them. And another thing is, for answering a nerve, you should have that mind mapping like this. So simple diagrams with a table, you will be able to reproduce the answer. So what is the criteria for answering a question is, it should be comprehensive, impressive, and accuracy. So comprehensive means complete, including all elements. Broad perception, you should have something about everything you should be know. And impressive is, it should be stunning, majestic, and looking grand. When a person is evaluating your answer, you should be impressive. So skill of presentation, your handwriting, tables, flowcharts, figures, talking skills, in the case of Viva, your personal appearance, all these will matter. And accuracy, precise, exact, right, specific, reliable, for which you should have some knowledge. Hope it is clear to all of you. Any problem, you should be able to tell me. And if this is okay, shall I proceed with the next one? Yes? Hello? బాగా పోతుందా? నాకు అది వెళ్తున్నది కదా ఫ్లో.
వస్తాం మ్యామ్.
Okay. So if you don't have any questions, I'm not seeing anything. If they are, at the end, we will see. Okay. Then the other topic is cubital fossa. So when a question on cubital fossa is asked, okay, don't think they won't ask. It can be asked. What you should know is how to start the introduction for it. What are the boundaries for it? What are the contents and clinical application? So what is the shape of it and where it is located? That is the one. Triangular depression on the anterior aspect of elbow. That's what you will be writing about it. And then what are the boundaries? When you are writing the boundaries, you will be having some confusion. So you should remember exactly what is the lateral boundary is the medial border of brachioradialis. That's what you have to write. Medial border of brachioradialis. Medial boundary is the lateral border of the pronator teres. And what is base? Imaginary line. Apex is meeting point of these two muscles. Then if you see the roof of it, what is the roof? Skin is there, then in order you have to superficial to deep. These orders also you should remember, where you should write superficial to deep, medial to lateral, lateral to medial, anterior to posterior. These are also important depending on that area of questioning. Then superficial fascia will be seen, and later what you will find in the superficial fascia is the cephalic vein you will be seeing, and lateral cutaneous nerve. So of forearm, this is the one you will see. Medially, you will be seeing the basidic vein and medial cutaneous nerve of forearm. And in the middle is the median cubital vein connecting these two veins you will be seeing with median vein of forearm. This is the median vein of forearm. Then what will be the deep fascia? So thickening of bicipital aponeurosis, which is called grace of God tendon, that is there. So what is its importance is median cubital vein is fixed for venipuncture because of this bicipital aponeurosis. A perforator vein is piercing that aponeurosis and reaching the deep veins. That is the importance of it. And what will be the floor? You can see the muscles. The brachialis muscle and supinator will be here, and you can see the bicep tendon and then the aponeurosis, and you can see the part of the contents of the cubital fossa also. And you should be able to draw a rough diagram, if not possible, just a line diagram. You show it and see the brachialis and supinator muscles in the floor. And what will be the contents? So medial to lateral, how to remember them? The median nerve, and the brachial artery you are seeing, and the tendon of biceps. And deeper, if you push this muscle, you can see the radial nerve you are seeing. So these are the contents of the cubital fossa. And the median cubital vein I am telling you, which pierces it, and then you can see the median cubital vein piercing the bicipital aponeurosis. So what is the clinical importance of cubital fossa? This is another aspect. Every question you should remember what is its clinical application. So try to read and write 1 or 2 points at least. So it's the gateway for major neurovascular structures between the arm and forearm. And it's a most frequently accessed area in everyday medical practice, either for diagnostic purpose or intervention purpose or surgical procedures. So what are the procedures? Median cubital vein, venipuncture and phlebotomy, blood pressure monitoring, brachial artery is here. Pulse palpation, brachial pulse you can palpate, and a common anatomical site for inserting central catheters and for hemodialysis, AV fistulas, and performing cardiac catheterization. If you earn for supracondylar fracture, those surgical procedures are also there. Let us not go deeper into that part, and that is about the cubital fossa. Now, another question that's of importance. Either you may get as a short notes question, you may get MCQs, or a clinically oriented question also possible is the axillary lymph nodes. So these axillary lymph nodes, why they are important is the lymphatic drainage of the upper limb, and another important structure is the mammary gland. And the lymph nodes of upper limb or the supratracheal nodes, the axillary lymph nodes and the infraclavicular lymph nodes, these are all the important nodes. And how they are divided, you know, all of you are aware of it. Anterior wall, posterior wall, and lateral wall of the axilla boundaries you should be familiar. Then you will be able to mention these. And apart from that, what are the parasternal nodes? And how the drainage of the mammary gland, for that I have shown in this picture, and we will continue also. So now you see at the boundaries of the axilla you are seeing, and the medial wall for the anterior, and then there is the posterior wall you are seeing, and then there is the lateral wall, lateral group, and central group you will get, and at the apex, apical group of lymph nodes. Total will be around 20 to 30 nodes you will be seeing, and how they can be mapped in a cut section. If you have a diagram like this, is useful for both the axilla and then the contents, and especially the nodes. For that, I'm not showing the other contents of it, but focused on the only the lymph nodes in relation with the anterior wall, anterior group where they are, posterior you are seeing, the central group you are seeing, the lateral group, because all these three will drain ultimately into the central group, which will drain into the apical group. And in relation with muscles and vessels also, you can see that's how subscapular group you can call this one, because they are, this is lateral thoracic group because in relation with the lateral thoracic wall. So like that you will be classifying them. And if you see here, so look at the anterior group, because this is the, you can see the axillary artery pectoralis minor. So lateral thoracic vessels. That's why this is the anterior group. And this is the posterior group in relation with the subscapular vessels and thoracodorsal nerve. And why we should know the importance, relations of these nerves is in the removal of the axillary lymph node, especially in carcinoma breast. You should not injure these nerves, and these nerves can be injured and results in paralysis of the muscles that are supplied by these nerves. That's why we should know the lateral group, axillary vein, they are related to it, and the central group, if you see, it is related to the second part of the axillary artery in general. Intercostal brachial nerve is related to this. Then if you see the apical group, it is related to first part of axillary artery and axillary vein. So this relation is also important. Then how they drain, what is the area? Now in this, you are seeing the picture of the axilla and the group of lymph nodes and how they will be draining anterior, posterior and lateral towards the central group, and from there to the apical. From the apical, how they will go into the supraclavicular, subclavian lymph trunk, and right or left venous angle it will go. That's how. And if you see the anterior group, yes, so the lymph from skin and muscles of anterior and lateral walls of trunk up to the level of umbilicus, it will be draining, and part of mammary gland also drain into this anterior group. Then what about the posterior group? So lymph and from the skin and muscles of back of trunk drain into this group, and it extends up to the lower, from the lower part of neck to the iliac crest. You can see the colored area. Then what about the lateral group? Whole of upper limb drains into this one, except a few vessels following the cephalic vein that can go directly into the apical group, and how they pass through the central and apical group, subclavian lymph trunk, thoracic duct, and where the subclavian and thoracic duct opens on the right side, left side, and what about the right lymphatic duct on the right side, you should be able to recollect that part. Then what is the clinical application of it? So enlargement of lymph nodes. Normal nodes, you cannot feel them. If there is infection or malignancy in the area of drainage, for example, mammary gland, so then they can be enlarged, and you should use bimanual palpation with palm of hand, right side nodes with the left palm. That's what you are seeing, and vice versa. That is how you palpate these lymph nodes. Then there is the, if there is a lesion of it, so what will be the lateral group? So whole of the upper limb except the one draining by the cephalic vein. Anterior group, anterior thoracic wall, abdomen, above the umbilicus and mammary gland. Posterior group, we have already seen the previous picture. And trunk to iliac crest, axillary tail of Spence also drains into it. Central group will be from these three groups. Then it will go into the apical group. Then there is the apical group drained by those lymphatics accompanying the cephalic vein. That is the importance of it. Then you can formulate a table also. So what are the lateral group is known as humeral group, and pectoral group is anterior, and subscapular group is posterior. Central, what is the central part? And then the apical group, where they are located, and what is the relation of vessels, which I have already shown you in the picture. So if you have that pictorial memory and organize them in the form of a table when you are reading, so you can give the relations of two vessels and nerves. And what is the area of drainage, I have already shown you. And pectoral group is important. 70% of lymphatics of mammary gland and muscles and skin above the umbilicus, it will drain, and then followed by posterior group. Okay. Then the lateral, anterior and posterior going to the central, and these upper marginal area of mammary gland goes into the apical group, and those accompanying the cephalic vein, other four groups, they will also go to the apical group. And they, where do they terminate? So humeral, apical and central, and few can go to supraclavicular. These will go into the pectoral, into apical and central, apical and central. This is only apical, central too. So efferents, they will form the lymphatic trunk, and I have already told you what will happen on the left side, and then the right lymphatic duct on the right side. So this you have to recollect. What is the clinical importance? Lymphadenopathy in the case of malignancy, upper limb, back of trunk, or anterolateral abdominal wall, or in the case of breast. So generalized lymphadenopathy also of reticuloendothelial system along with cervical, you will be seeing this. Inguinal, all will be enlarged, and if there is the lymphangitis of hand and forearm, lateral group will be affected. So if there is abscess from the anterior set, so it will point at the lower border, the pectoralis minor muscle. That's how we can understand if you have the surface anatomy and the locational knowledge. Carcinoma of breast, what will happen? Apical set is adherent to axillary vein. So one has to be careful when you are excising the tumor. and central set will enlarge and press on the intercostal brachial nerves. That's why they complain of severe pain on inner side of arm after the surgery. Then lymph node biopsy also, surgical removal and observation under microscope for grading the cancer. Sentinel biopsy is a few lymph nodes into which the tumor drains. They will remove it, and by injecting a tracer material, they will identify the node during surgery. And then if the node is they observe under the microscope and find out that cancer cells are present, then they have to go plan the surgery accordingly. So absence of cells indicates that there is no spread to lymph nodes, and it is or other organs. It is confined to the breast only. So those are the uses of sentinel node biopsy. So once we know this part, now the lymphatic drainage of mammary gland is easy for you if you have knowledge of the axillary lymph nodes. Axillary lymph nodes is a short notes question. Lymphatic drainage of mammary gland also is a short notes question. So, if there is a case scenario, a 50-year woman with a complaint of painless lump in the upper and outer quadrant of her left breast. So hard irregular lump was felt in that quadrant, and retraction of the nipple. This is what you are seeing in the lower picture. Enlarged axillary nodes were observed. So you should be able to give anatomical explanation for the clinical description, and you should have the knowledge of mammary gland, its blood supply, lymphatic drainage, and histological structure. So you may be asked a question, describe the mammary gland under the following headings. So each heading you should be able to answer, and there will be distribution of marks also. And what are the important points you focus first, then you can add some more details if you have sufficient time. So you are seeing the mammary gland, what is nipple, what is areola, and axillary tail of Spence you are seeing. You have read the theory. Now you will be able to answer, and what type of gland you have to mention, and what is its location and its extent. What it is in the superficial fascia except tail. So superficial fascia which splits to enclose it. So what is its shape and what is its extent? You should be able to give vertical extent, second to sixth rib, horizontal extent, retrosternal line to mid-axillary line, and how it extends into axilla in the form of an axillary tail of Spence, and which passes through a foramen in the deep fascia, foramen of Langer. So these some of the terms you should remember when it is asked, because these can be given as an MCQ. Then what are the parts of it? You know, what is base, apex, axillary tail of Spence. You should have a lateral view diagram also, which will be of help, and for giving the base, what are all the components you will be seeing. Then if you see base, superficial to deep again, retromammary space is the one which is important. And what is pectoral fascia? Deep fascia on the pectoralis muscle, and what are the muscles you will see. And there's, you can observe the what is retromammary space. Then what is pectoral fascia, pectoralis major muscle. This is the base. So you can see the components of the gland at the nipple. You are seeing the lactiferous sinus openings are there. Then the lactiferous ducts, the alveoli you are seeing. This type of picture also you should practice. Then what is the base? The retromammary space we have mentioned is a loose connective tissue which is separating the gland from the muscles, that is pectoral fascia, and it is the one for the movement of the breast over the pectoralis major. If it is fixed, means in the case of malignancy, it is fixed to this, and it is the place is important for placing the breast implants. So how they place the breast implant, you can see in this retromammary space. Then if you see what are the muscles it is related, the base. So pectoralis major 2/3 and serratus anterior lateral 1/3. Inferior, you can see the external oblique muscle of abdomen and aponeurosis are related to it. And this is the dissection. You correlate it with the pectoralis major serratus muscle, you are able to see in this one. And what will be the apex is areola on nipple, center is the nipple you are seeing it, and at the level of fourth intercostal space, that is the important, and correlate it with what about the apex beat, where you will feel for the apex beat. Then areola is this dark circular area around the nipple you are seeing. Then the axillary tail of Spence you are seeing, prolongation of glandular tissue will be there. So superolateral part, it is there, extending to the lateral to pectoralis major muscle, passes through foramen of Langer, and it is in contact with the lymph nodes. This should not be mistaken for a lymph node. That's the importance of it. And yes, it can be mistaken, which is palpable, can be seen during premenstrual period. So this can be seen. Then there is the structure. What is the structure? You have to mention skin, parenchyma, stroma. What is skin? Again, that you have to mention about the nipple, areola, and behind the areola, how it will be. Then the glandular tissue, parenchyma means. What are the lobes you are seeing? Lobules you are seeing, rectified ducts you have to mention. And what are alveoli, secreting units? And the stroma is the fibrous connective tissue you are seeing. 1 minute, any call? And what will be the structures that will be seen at this point? And what about the retromammary fat also you should focus. Then there is the central part, is the nip. Let's me see. Okay, central part. So there is a conical projection. You are seeing nipple. And what is the space? How many lactiferous ducts you will be seeing? And absence of hair and sweat glands, rich sensory innervation, contains the circular and longitudinal muscles, and its role in erection also you should be able to recollect. And here if you see the areola, okay, circular area around it, and you are seeing the tubercles, Montgomery's tubercles. So because of the underlying sweat glands, sebaceous glands, it will be seen. So beneath the areola also there is no fat, lactiferous sinuses and ducts only you will be seeing. Okay, so what are the lobes? 15 to 20. Each having its own duct is there. Dilated part of duct is sinus, and how they are arranged, radially arranged ones, and lobules, such breaking up of ducts into ductules. Ductules will be lined by columnar epithelium, and you should be able to draw the alveoli or acini, what will be in the non-pregnant condition, and what will be in the pregnant, and what will be during the lactation. You can plan for diagrams on this structure of it. And what about the connective tissue? Fibrous tissue in the form of septa, and you call them as the ligaments of Cooper. See, so many names are there which you should remember in this one. So interalveolar and interductal fat is there. So which is responsible for the cushioning and rounded contour and maintenance of temperature. And retromammary fat also, how it protects the gland from external injury. And coming to blood supply of it. So arterial supply, venous drainage. That is another mistake you should, when they ask blood supply, both arterial and venous part you have to write. And what is the blood supply? Is from the axillary and subclavian arteries. So there is a lateral set of arteries from the second part of axillary artery. So they are the lateral thoracic artery and acromiothoracic or thoracoacromial arteries. From the medial set, medially is the internal thoracic artery, which is coming from the first part of subclavian artery. So it will give the perforating branches, arteries, second to fourth intercostal spaces, and anterior intercostal arteries also, they will be supplying it. There is a deep set is there. Second to fourth posterior intercostal arteries are there. And second is from the superior intercostal, from the costocervical trunk, and second part of subclavian. Third and fourth from the thoracic aorta. So all these are entering on the anterior surface. Then what about the posterior surface of mammary gland is avascular, and that is called lake of Marseille. So which can be an MCQ for you, lake of Marseille. Then what about the venous drainage? So all of them, they are draining towards the nipple, around which there is a circulus venosus is there. From there, the circumferences of the gland, the veins will drain, and then they will be draining into the internal thoracic vein, then the axillary vein you are seeing, then the posterior intercostal veins it will go. This posterior intercostal vein is connected to the vertebral venous plexus. That's why there will be secondaries in the vertebra and ribs in carcinoma of breast. If they ask a question like this and give your explanation, this is the explanation you have to give for that question. Then what are the nerves or intercostal nerves? Then sympathetic, sensory, both will be there. Secretions can be, what are the secretions? You have the knowledge of physiology, you can add some of it. And lymphatic drainage of mammary gland. And if you want to elaborate it, you have to mention what is the parenchyma, lymphatic drainage, having superficial and deep sets are there. And stroma is also having superficial and deep sets. And if you want to classify it according to lymph node wise also you can do it, and quadrant wise also you can do it, and provided you understand it, and then only you can do it. Otherwise simply put this side one, and if you can elaborate, or like parenchyma, superficial set, upper marginal, where do they go? Upper and lower lateral, where do they go? Medial, where do they go? And the deep set is parenchyma. So it forms a plexus, perilobular, subareolar plexus, hallux plexus, from there to regional lymph nodes. And from the regional lymph nodes, how they can go to the central apical and then to the parasternal intercostal, supraclavicular, subdiaphragmatic and opposite, or quadrant wise also. I'm going to elaborate because I'm going to show them repeatedly. So parenchyma, superficial set will drain the skin except nipple and area, they go separately. And this is upper marginal, they will go to the nearer ones, apical and infraclavicular, upper and lateral plus axillary tail. It can go to the pectoral group of lymph nodes. So you can see the arrows going there, and anterior abdominal wall also they can go lower and lateral. And then the medial, they will go to the sternal group, same side, and to the opposite side. You can see the arrows, and you are seeing it divided into 4 quadrants, the mammary gland. Then there is the, from the deep set, parenchyma plus skin of nipple and areola, which we have missed there. They will go to the deep set, and they form the periglandular and periductal plexus. There is a subareolar plexus of Sappi around the nipple and areola. This is also an MCQ. So, in relation with the fascia on the covering the pectoralis major, there is a plexus that is called lymphatic lake of Haller. So, upper part, where how they go to the apical group of lymph nodes, upper lateral, same as pectoral, upper medial, they will be going towards the sternal, lower lateral, how they go to the pectoral, intercostal, anterior abdominal wall, lower and medial, they will go to the sternal, opposite side also they will go. So like that. And I was mentioning about the perilobular plexus. See the picture. And this is the subareolar plexus of Sappi you are seeing. And this is the Haller's plexus, lymphatic lake of Haller. From all these, they will go to the regional lymph nodes, which we have mentioned. Okay. Upper part, they go to the apical nodes, and then the superolateral, they go to the anterior or posterior, superomedial, go to the same and opposite side, sternal, and infrolateral quadrant. Okay, they can go to the pectoral group, anterior or posterior, and intercostal, and inferior-medial, sternal, and opposite side. Lowest part of medial area, you have to focus. This is again a clinically important one. It passes through the subperitoneal plexus of rectus sheath, and then along the falciform ligament. It can go to the hepatic nodes or peritoneal cavity. Droppings will be there, and it can go towards the uterus, and this is called path of Gerota, and it produces a tumor we call the Krukenberg's tumor. So this is another clinically important condition. So superficial stroma, superficial along the skin, deep. Here you remember. Axillary lymph nodes, 75% of mammary gland drains. Parasternal, 20%. Intercostal, only 5%. And if apical, another way of division is axillary pathway, subareolar plexus center 70%, apical plus supraclavicular 5%, parasternal are 20%, posterior intercostal 5%. Like that also it can be divided. And this is the whole picture of lymphatic drainage, which I have mentioned. So if you have knowledge of this type of diagram, and these quadrants also, you will be in a position to answer for the lymphatic drainage. So the microscopic structure. So what you have to focus, just like any gland, you should be able to focus on the secreting units, alveoli, and then the duct system and the interlobular connective tissue. So non-lactating part, what you will be seeing. So glandular part and ducts will be there, and the lobules will be poorly demarcated, and alveoli will have only solid cords of cells will be there, and interlobular connective tissue and adipose tissue will be more. And in the case of lactating mammary gland, okay, this is a non-lactating one. Okay, this is what you are seeing. So you are seeing more of adipose tissue you are seeing, and the alveoli not differentiated. You are seeing the duct system cords like that you are seeing, and then there is and if it is an active lactating mammary gland, see how they are you are seeing the glandular component is more, connective tissue is less, well-defined alveoli, some secretions also you are seeing, some of the alveoli. So the ducts, intralobular will be cuboidal, lactiferous ducts will be the stratified epithelium. There's another one you have to remember. See you can draw a diagram like this for the microscopic structure. And then what about the development? So it's a modified sweat gland. So development begins at the 6th week. Bilateral it is, thickened strip of ectoderm you are seeing, mammary ridge you call it, extending from the mid-clavicular to the mid-inguinal region. Okay, so it will regress over the entire area except in the pectoral region where it develops into the mammary gland, and where the ectodermal thickening will be there, downward growth will be there. That is the primary part, which shows multiplication. Okay, extensions, that is called the secondary part, and it is going into the adjacent mesoderm you are seeing. And the 3rd month, the depression in the center will be in the pectoral region. It will start. Then in the 5th month, the solid buds you are seeing extending. The central buds, they get degenerate and canalize the duct system. But okay, and then the terminal parts of it, secreting units, duct system and nipple will be formed. And at the time of birth, a version of inverted nipple will take place. That is the development. And developmental anomalies also, absence of mammary gland, prepubertal stage persistence, micromasia, macromasia, gynecomasia, male breast developing like females, polyaccessory breast, absence of nipple, accessory nipples, inverted nipple. These are all the abnormalities possible. So what about the postnatal development is no secretory apparatus at birth. Newborn, nipple is inverted. Nipple elevates during the childhood. Then at puberty, breast enlarges because of deposition of fat, alveoli development, secreting cells development, hormonal influence. So after birth, there is the age-related changes, which milk is possible. There, no growth in males. Females before puberty, what will happen? Elevation of areola, gradual development will be there, enlargement and deposition of fat. At puberty, what will happen? The duct system, alveoli, cyclical changes are there. During pregnancy, old alveoli will proliferate and new will be formed. Then during lactation, fatty degeneration of cells, which will form the cholesterol and distension with milk. During menopause, again, involution will be there. Then coming to the last part, applied anatomy is infections, breast abscess, cyst, benign can be lipoma, fibroadenoma. Benign tumors will be smooth, mobile and soft. And if there is malignancy, they will be irregular in shape, immobile and hard because they can get fixed to the pectoral fascia. And if a question can be asked in case of carcinoma of breast, give the explanation for dimpling of skin, purely orange appearance, retraction of nipple, and radiological examination of skeleton. Why it should be done? So these are what is that? Purely orange is lymphatic obstruction. Retraction of nipple, it can be congenital or retraction due to carcinoma. And what is dimpling of skin also? Let us see the picture. This is what you are seeing, this type of appearance, and what does it indicate? So this is the dimpling of skin, and you are seeing the ligaments of Cooper. The importance of ligament of Cooper is they are pulling because of the cancer cell. This ligament of Cooper's, they are pulling down the skin. That's why this appearance, dimpling of skin, is possible. That's the explanation. What is the basis for retracted nipple? This is the malignant tumor. Yes, lactiferous ducts expansion will be there. So the growth is extending along the lactiferous duct and it causes fibrosis of it. This causes retraction of it, retraction of the nipple. Okay, perimenopausal is also possible in other diseases. Also, it is possible, especially carcinoma of breast. You should be able to give the explanation for it. And another thing, this is the appearance you will be seeing. What is the anatomical? What's the explanation? So, what do you call this condition? It's called purely orange appearance. And what is the anatomical basis for it? You are seeing the lymphatics, blackness of this cutaneous lymphatics by these malignant cells you are seeing in this. And that can cause the skin becomes edematous, you are seeing. And hair follicles there, they can get buried into the skin. That's what is happening here. That is responsible for the orange pale appearance or purely orange appearance of the skin. And what are the diagnostic investigations? Mammography, ultrasound, ductography, and biopsy. Sentinel, you know what is sentinel? Excision biopsy, fine needle aspiration, and computer and imaging, stereotactic guided biopsies also, they can be done. And you are seeing the mammography, how it will look like, normal one, and benign lymph node, and if there is a focus, how to identify it, and how to identify the cysts, you can see, and the malignancy of lobular carcinoma can be identified, and what will be the route of spread. And because we know already, this explanation I have already given, so focus on that part for the spread of it. So with this, I think I have completed it. Any clarifications? Yes. Hello. Amma, అయిపోయిందిరా ఏమన్నా clarifications? If you have any doubts, put in the chat box, ma. I will be able to see the chat box. Hope I am audible.
Yes, ma'am.
Yes. Chart received. To look at the chart and trying to look.
It seems ever came doubts slave, ma'am.
Pardon?
Ever came doubts slave.
No
ma'am.
doubts?
No, ma'am.
Oh. That means they are very thorough with it. Okay, good. Is it? And share their view. Whether did they complete what they need, or is it too much or too little? Yes.
It seems they have no doubts, ma'am. All of them are replying no doubts.
Pardon?
Thank you, ma'am.
Okay. Okay, good. Then I think now I am looking at the chart. Chart. Okay.
Yes, ma'am.
Okay, then. Shall we close it?
Yes, ma'am.
Anything
One-
else? If they want, they have the email or something else, my number, they can do it.
Okay, ma'am.
Okay, ma. Thank you.
What are the topics in upper?
Pardon?
They are asking what are other topics in upper limb should we revise?
Okay, upper limb. So mammary gland, now you are thorough, and nerves also. Ulnar nerve in hand, you should know. Definitely. Musculocutaneous nerve can be asked. Axillary nerve is another one which can be asked. Because of 1 hour constraint, I have limited to that 1 hour only. Then the venous drainage, median cubital vein, that is another one. Axillary artery itself is a question for them. Then the anastomosis around elbow and scapula, let them have a brief diagram and with the points only, not elaborate ones. Then the other one is joints, shoulder joint, carpometacarpal joint of thumb, supination and pronation. These are the commonly asked questions. So arteries, lymph nodes we have completed. Venous drainage, veins, median cubital vein. So nerves, important nerves you have to focus, brachial plexus and nerves. The joints, then muscles also. Pectoral is major muscle. They can be asked deltoid and structures under cover of deltoid. Okay, so these are some of the important ones. And then superficial and deep palmar arch. The flexor retinaculum, extensor retinaculum. One of them they can be asked. Then is a radial bursa, ulnar bursa. Fascious spaces in the palm. There is another one. They have to do it. I think these are cutaneous innervation of palm and hand, dorsum. So how it will be separated? Ulnar nerve what part, radial nerve what part, median nerve what part, and why they are up to the terminal part, terminal phalanges from the palmar aspect. Give embryological explanation. There's also can be given as a question. Then access artery of upper. So like that for the lower limb also more or less similar. They can be. If they are thorough with upper limb and lower limb, and in each paper they can get 10, 15 marks easily. That is the importance of it. Then if they are thorough with thorax and brain, another 15, 20 marks they will get it without any problem. Each paper, I'm telling. Then similarly, head and neck and abdomen and pelvis. So the distribution they should know, and definitely they will get a question in embryology, histology, each one, 5 marks you will get in each paper. Embryology and histology. Let it be general or relevant. So there's also a scoring one. Like that. And genetics, one question, 5 marks. They should be prepared for that. That is the important come. And another way, outcome questions are there, 5 marks. Like that, they should distribute paper-wise, the prioritize it, they do it. And upper end of humerus, it can be asked as a question. So bicipital groove, such clavipectoral fascia is another question. They will get it. Anything else? Did I cover?
They are saying thank you, ma'am.
Okay.
Ma'am, shall we conclude the session?
If they say yes, we can say yes.
Respected Shubadra ma'am, Emeritus ma'am, thank you for your inspiring and enlightening session. It's truly a privilege to learn from a teacher like you, ma'am. The title of Professor Emeritus, conferred by Dr. NTR University of Health Sciences, is a prestigious honor recognizing your exceptional contribution to medical education. We feel incredible, fortunate to have the opportunity to learn from you, ma'am. We extend our heartfelt gratitude to Dr. Shubadra ma'am for an insightful and enriching session. Thank you, ma'am, for your valuable time, guidance, and unwavering support. Thank you, all the participants, for your enthusiastic presence and active participation. Let's conclude today's session by Shanti Mantram. सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः. Thank you, ma'am.
Thank you, Ma. Thank you, one and all. All the best.
Thank you, ma'am.